Hello, everyone. Welcome you all for the WEO Research Webinar series. And this is the second part of the series here today, and we'll be reviewing how to critically analyze a paper. I am Professor Krish Ragunath. I'm a consultant gastroenterologist and professor of medicine at Royal Perth Hospital and Curtin University in Western Australia. I'll be chairing the session today. I have with me a stellar faculty. We have Dr. Fauze Maluf, who is very well known in the endoscopy circles. He's a director of endoscopy at the University Hospital Sao Paulo, Brazil. And importantly, he's associate editor of the GI Endoscopy Journal. So Fauze is going to be the speaker for us today, and he'll be going to be talking about how you would critically analyze paper. So I'm joined by two of our panelists. We have Dr. Purnima Bhat from Canberra in Australia. Purnima is a consultant gastroenterologist and hepatologist and has a special interest in endoscopy. She's also an editorial board of Scandinavian Journal of Gastroenterology and has published quite extensively. So Purnima will be one of our panelists. Along with Purnima, we have Dr. Roque Sáenz from Chile, University of Del Salvador. He is quite an experienced endoscopist and gastroenterologist, quite very well published in this area. He's also director of the Chilean Society of Gastroenterology. So welcome to you all. And I'll leave the stage to Fauze to kickstart with the presentation. Thank you, Fauze.
Thank you. Hello, everyone. Thank you, Krish, for the kind introduction and for the wonderful invitation for this webinar. Is sponsored by WEO Research Committee. I'm pretty honored and happy to be here today, especially with my fellows, my dear colleagues, Professor Purnima Bhat and Roque Sáenz. So I'm gonna, can you see my presentation in full screen?
Yes, everything okay.
Yes, great, thank you. So I have no relevant conflict of interest for this presentation. And I'd like to open this presentation with this survey that was published in Science last year on the level of confidence of scientists on scientific research. How much do you believe in clinical research? And as you may see here, a fair proportion of scientists do not believe or have some disbeliefs on scientific research. And this is probably because of the low quality, because we are all aware of the low quality of scientific research that is published. We know that in academia it's essential to keep publishing, but probably this is not the main reason. This should be not the main, shouldn't be the main reason for publishing. And maybe this could explain the low quality of some papers that we see published. So quoting Doug Altman, I would say that we need less research, better research, and research done for the right reasons. You are all aware of this pyramid, the pyramid of the hierarchy of research designs and the consequent levels of scientific evidence. Unfortunately, most papers published in our area in endoscopy are observational studies, case reports, or case series. But I'm gonna focus my presentation on the reading of randomized controlled trials and systematic review and meta-analysis, because if you can deal with these higher quality papers, you can definitely deal with lower quality studies. So the first step when I receive a paper is to read attentively the title and the abstract, and I try to extract the research question and fit the research question in the Picot or Packot system. So an example here. This study was published in New England Journal of Medicine last year. It's about the timing of endoscopy for acute upper GI bleeding. So the authors included patients with overt signs of acute upper GI bleeding with Glasgow-Blatchford score of 12 or higher, and randomized them in two groups. The first group, the intervention group, should undergo endoscopy within 6 hours. This is urgent endoscopy group, and the control group should underwent endoscopy between 6 and 24 hours. And the outcome, the main outcome that was adopted by the authors was the death from any cause within 30 days after randomization. So the research question is very clear. So I want to know if by doing urgent endoscopy, I'm gonna impact mortality within 30 days in patients with upper GI bleeding. So the PICOT is very clear. Population, patients with overt signs of upper GI bleeding, acute upper GI bleeding with Glasgow-Blatchford score 12 or higher. The intervention is urgent endoscopy within 6 hours. The control group, very clear, endoscopy between 6 and 24 hours. And the outcome, death from any cause, and the time within 30 days. So this is the PICOT system, and we should try to do this exercise for every paper that we read. So going back again to research question, is that feasible, interesting, novel, ethic, and reproducible? And that's what I expect from a research question. So this is the final system. And is it plausible? It seems very, very, very basic to ask if the research question is plausible, but just to increase our awareness on this issue, some authors published in British Medical Journal 2018 this interesting study about the use of parachute to prevent death when you jump from aircraft. So they screened almost 100 patients and randomized 23 of them, 11 for the control group, parachute, and 12 patients with no parachute. And here is the famous table 1. And as you may see here, most participants, they jumped from biplanes and helicopters. When you look here in the velocity, in the speed of the aircraft was 0. So for sure, the participants jumped from a landed aircraft. So that's why they accepted. So this study is just to increase our awareness of the importance of the plausibility of the research question. So we extract the research question from the title and abstract. We use the PICOT system. So first, second step, and now the third step, to evaluate the quality, the intrinsic quality of the study. This is internal validity, and the third step. So in order to answer the research question, did the authors employ the correct study design? This is very important. And if the answer is yes, now I'm gonna check some minimum requirements for this study. And this is widely available in the internet. You can check you can have to see some checklists on the study designs, and including the risk of bias for systematic review, meta-analysis, randomized control trials, cohort, case control, transversal, and even case series studies. Here are some of them for randomized control trials. So you can check the risk of bias in the ROB2, and there are all these checklists for randomized control trials, the minimum requirements for randomized control trials. You find it on the internet, the SURE, the CASP, the GBI, and SIGN. So going back to the PICOT system, I'm gonna analyze the population that was studied. For sure, the authors wanted to study all the patients in the world with upper GI bleeding, but this is not possible. So they have a target population, an accessible population, and finally, they're gonna employ inclusion and exclusion criteria and reach the sample population, the real population of the study. And we expect that this population will represent the whole population of bleeders. This is inference. So we should analyze very carefully the inclusion-exclusion criteria, because the population was formed based on these premises. So the clinical aspects of the patients, the severity of the disease. Remember in that study, Glasgow-Blatchford 12 or higher means severe bleeding, clinically meaningful bleeding, previous treatments, no previous treatment. That's important. And more important of everything is if the authors included all consecutive patients, or if not, this is really a clear source of selection bias. And in randomized control trials is that I expect to see this flow diagram. The number of patients that were assessed for eligibility and the excluded patients and the reason for exclusions the number of patients that were randomized, how they were allocated, the follow-up, the lost patients of follow-up, and the reason for lost follow-up, and finally, the number of patients that were submitted to intervention and control. Now we're going to analyze the intervention and control. The intervention, usually in our area, is really an endoscopic intervention. A new endoscopic intervention should make sense. And in the method should be detailed, described like a pie recipe. We should take into consideration the experience of the operator, the learning curve. Concerning the control group should receive the best treatment available. Sometimes placebo is not the best treatment available. Sometimes the intervention that was offered to the control group is not the best treatment available, and we should take this into consideration. Once again, detailed description of the intervention of the treatment received by the control group, the experience of the operator, the learning curve. And very important, the post-intervention care should be the same for the intervention and the control group. And we should take into consideration the hierarchy of the center. To analyze a study with 10 from a center where 10 ERCPs are performed every month is different from analyze a paper from a center where 10 ERCPs are performed every day. So tertiary academic centers, high volume centers, probably different paper from low volume centers. There are books dedicated on the description of adequate randomization. But summarizing this information in one single slide, the randomization strategy should be described very clearly in the paper. This is very important. The randomization should be concealed in a way that the investigator cannot cheat and cannot see the randomization of the patient before the intervention. And both the patient and investigator should be masked or blinded for patient's allocation. Talking about the outcome should be clinically meaningful. This is of paramount importance. In patients dealing with acute pancreatitis rate, obviously the clinically meaningful outcome is acute pancreatitis rate, but so many times I've seen papers talking about the mean level of hyperamylasemia. Papers on esophageal stricture, clinically relevant outcome for sure is dysphagia, but once again, I read weight gain. GI bleeding, the clinically relevant outcomes are bleeding control and mortality, but we read instead transfusion needs and length of stay. And this goes on and on. This happens probably because these intermediate outcomes, they are easier to obtain, they are more frequent, so I need a smaller sample size. But for the patient, this is what is important. So we as authors, we can adopt intermediate outcomes, but they should be real surrogate outcomes. It means that if the patient has this outcome, it's very probable that they had the clinically meaningful outcome. So we can adopt real surrogate outcomes in clinical trials. And I'm going to analyze if the outcome was dichotomous or numeric, if it was a score, if it says a score, it's validated, is widely accepted. Sample size calculation is very important because most papers, unfortunately, most papers in randomized clinical trials, they are underpowered to show that difference. And finally, if the paper was a superiority clinical trial, I want to show a real difference, or is a non-inferiority clinical trial. I just want to show that the intervention is not inferior to the control intervention. So once again, surrogate endpoints are acceptable if they are exactly in this chain: disease, intervention, surrogate endpoint, and the patient, if has a surrogate endpoints, probably it will have the true endpoint. Even the Food and Drug Administration, the FDA agency, accepts surrogate markers to approve a product, a drug that was tested in a clinical trial, if the surrogate marker is probably means the real, the clinically meaningful outcome based on epidemiologic, therapeutic, pathophysiologic premises. Regarding the sample size, once again, there are books explaining how to calculate sample size, but summarizing this as a single slide. When you look at the sample size, what's the main purpose of the trial? The sample size calculation is based on the main outcome and on the treatment difference that you're expecting to find. So when you begin the study, when you plan the study, you have a hypothesis in your mind. What is the treatment difference that you expect? So with the control treatment, I expect, based on the literature, a 10% mortality. And now with this new treatment, with this new drug, I expect half mortality, 5%. And based on the outcome, mortality, and based on the treatment difference, I'm gonna perform the sample size calculation. So the good study, the good clinical trial should have a very clear defined study population, plausible and feasible intervention, good gold standard treatment for the control group, correct allocation, clinically meaningful outcome or a valid surrogate outcome, adequate sample size, and intention to treat analysis. Or at least to present both intention to treat and per protocol analysis. Finally, we go to the fourth step, the results. So as I mentioned before, the authors, they have a hypothesis, and based on the results, they're gonna accept a null hypothesis, so there is no difference between control and treatment, or they're gonna reject H0. They're gonna reject the null hypothesis, and they're gonna accept that there is a difference between the intervention, the results with the intervention, and the results with the control. And now we're gonna read how they stated the magnitude and the precision of this difference, of this effect. So here I present you the results of two papers, the red paper and the black paper. They both present the relative risk with the corresponding 95% confidence interval. So both papers, both studies show the same magnitude of the effect. Relative risk of 2 means that the mortality was twofold in one group compared to the other. So you see exactly the same magnitude. But let's take a look of the precision of the effect. In the red study, if I repeat the study 100 times, I expect that in 95% of the times, the relative risk, the effect will be between 1.8 and 2.2. Very precise study, very good quality study. Differently, in the black study, if I repeat the experiment 100 times, I expect in 95% of the times that the relative risk will be between 1 means no difference, until 3. Threefold increase, for example, threefold increase in mortality. So if I'm reading a paper like this, probably I will be not confident with the conclusions, and I'll be not confident to adopt this new treatment for my patients. But if I read this paper, yes, I'm gonna be more confident to adopt, to employ this new treatment for my patients. Another important point is the way that the authors present the results. So here are 4 different ways. The effect of the drug was statistically significant. Okay. The effect of the drug on reducing the mean hepatical portal pressure gradient, now I have the outcome, was statistically significant, P below 0.05. The effect of the drug on reducing the mean hepatical portal pressure gradient from 18 to 19 millimeters of mercury, now I have the main outcome and also have the magnitude of the effect, was statistically significant, and now I have the value, the p-value, 0.02. And finally, the effect of the drug on reducing the hepatical portal pressure gradient by a mean of 5 millimeters of mercury, 95% confidence interval, 1 to 9, was statistically significant. So I have the main outcome, I have the magnitude, I have the precision. So very transparent presentation of the results. So using this drug, I may reduce the hepatical portal pressure gradient by only 1 millimeter of mercury. So this is not very important, but okay, this is the way the results are presented. That's the way that I find the paper is very transparent, very well performed. So this is an infographic of this presentation. You have a paper, so you extract the research question, you ask yourself if the research question is feasible, interesting, novel, ethical, and reproducible. You're gonna check the robustness of the study, the internal validity, the level of certainty of the results of the effect, and then you're going to decide if you're going to employ clinically or not this new drug, this new treatment. And this is called external validity, if the results apply for your patient in question. I'm going to spend the last minutes of my presentations talk about systematic reviews and meta-analysis. Whenever we read a book chapter, we are reading a narrative review. That's a broad review on a specific subject. But systematic reviews differently. They are focused on a specific question, a research question. Is that drug better than, is that drug A better than drug B? So this is a very narrow, very specific research question. And if I find good quality papers that were more or less similar in the methodology, then I can summarize all the results, considering that all the papers will act like one paper and perform a mathematical summary of the results. This is called meta-analysis. It means that I must have a very good quality systematic review to produce a meta-analysis. But sometimes I can come to the conclusion that it's impossible to perform a meta-analysis. It's not ethical to perform a meta-analysis after performing a very good quality systematic review, just because I do not have good quality papers. And in the last 20 years, we observed a 5-fold increase in the number of published randomized controlled trials and a 50-fold increase of the number of published systematic review and meta-analysis. And why are authors submitting and journals publishing so many systematic review and meta-analysis? Because they are easier to conduct, cheaper, they do not require extensive regulatory process, they are highly cited, and unfortunately, 1/3 of them are methodologically flawed, and half of them are redundant or otherwise do not provide new information. So we editors, we have this challenge to balance impact factor, because when we accept a systematic review and meta-analysis for publication, we know that the citations will boost our impact factor versus the scientific mission of the journal. So I present you the famous GIGO for systematic review and meta-analysis. GIGO means garbage in, garbage out. If you have low quality primary studies, you certainly have low quality systematic review and meta-analysis. If the evidence generated by these studies is low quality, it's impossible to increase the level of the evidence because you conducted a meta-analysis with these very studies. This is basic on meta-analysis, but we see this error, this mistake, repeating and repeating endlessly. So the elements of high quality systematic review meta-analysis, they resolve a clinical quandary. The evidence suggests different courses of action based on well-done primary studies, and then use a systematic review meta-analysis to try to resolve the question. And a good systematic review meta-analysis have insightful sub-analysis, help to identify specific populations where approaches are optimal, and is possible based on meta-regression stratifying analysis. And they provide power to resolve vital questions because the primary studies, they have smaller sample sizes. Some troubled systematic review, some problematic systematic review and meta-analysis. So we are receiving all of a sudden 4 or 5 systematic review meta-analysis, 4 or 5 submissions, because 1 or 2 high impact randomized controlled trials were just published. So the authors, they lump these 1, 2 good studies with the former poor quality retrospective studies, and they conduct a meta-analysis. So we call this a premature meta-analysis. Another example of problematic meta-analysis, all the primary studies show the same effect. So this meta-analysis lack novelty. If you pull together all the studies, you probably find the same conclusion. And I invite you to read this paper that James Buxbaum from California and myself published last year in GIE, talking about tackling the problem of systematic review and meta-analysis. And here are some common mistakes that we have mentioned in that paper. The first mistake is to conduct the meta-analysis itself. So you have performed a very nice systematic review, but there are no good quality papers that credential you to conduct the meta-analysis. Second, I have already mentioned, is to lump and analyze good and bad quality studies together. And I'm going to present you an unfortunate vicious cycle of systematic review meta-analysis that I've been seeing repeatedly in endoscopy. This is very common when there is a novel endoscopic procedure. Very common, for example, when LAMS appeared, was the use of LAMS for pancreatic fluid collection was described, or even for new bariatric procedures. So you see in the literature, all of a sudden, 5 or 6 new case series with this novel endoscopic technique. So case series with 5 patients, 10 patients, 12 patients. And then following this case series, there is this multi-center trials that lump together all these case series. Now you have 80 patients, the same patients that were described in this case series, they are here in this multi-center trial describing, pulling together the results of all the case series. And all of a sudden, someone has the brilliant idea to perform a systematic review and meta-analysis, lumping together all the case series and this multi-center trial. But these are the same patients. And unfortunately, sometimes these systematic reviews are published and they're highly cited, but instead of offering good quality science, these publications are just amplifying bias. They are low quality studies, and there is a scandalous patient overlap. So please reject this kind of publication. If you want to know more about systematic reviews, I invite you to read the handbook published by the Cochrane collaboration. So Mrs. and Mrs. Chairman, I'd like to show you my take-home message. First, you should try to extract research question from the title and the abstract, and to reason if it's feasible, interesting, novel, ethical, and reproducible, and if it's plausible, very important. You should take a very good look at the main outcome, if it's clinically meaningful, or is just an intermediate outcome, or is a real, true surrogate marker, a true surrogate outcome. Take a good look at the study population, because the study population is a significant source of bias. And when you find a systematic review and meta-analysis on the subject that you're studying, and you think that you have resolved all the problems of your patients based on the results of this systematic review, please curb your enthusiasm. So I hope that this presentation have helped you to take the red pill and be awakened for this world of scientific research. And I hope seeing you soon in person in future meetings, and hope you are healthy and safe and have a wonderful holiday season and Happy New Year. Thank you so much.
Thank you, Fauze. That was really excellent presentation, and very interesting, and in fact, a very thought-provoking presentation. So there are some questions coming through. Whilst I go through the questions, I'll first kickstart one for you. So what would be your, obviously we have a global audience of different experience. We have trainees, we have established consultants and practitioners logged in. So what I would like you to tell us is, with your junior doctors, trainees working in your unit, how do you start them get involved in reading a paper, and what advice you give them to how they start doing this?
Okay, thank you, Krish. Thank you for your compliments, and thank you for your question. So I think that we who are senior, at least myself, consider myself a senior, so we should conduct these journal clubs. This is very important. We have this journal club in a weekly basis, when we ask the fellow to organize the presentation of 1 or 2 published papers. It's important that we select the paper and tell the junior faculty or the fellow to present it for us. And then during the presentation, we try to show all these aspects that I have already shown you during my presentation. I think that's a good way to introduce this team to them.
Thank you. Thank you. I think that's a very valid point, what you said about choosing the right paper and having a look at the paper with their trainee and maybe a day before to see how they prepare the slides and what they're doing, and then giving a feedback to them once you've presented it along with the colleagues. Good, very good. So we have one question here from Quang Trang Tran. The question is, I'm a novice in meta-analysis review, but want to do it in future. Could you please share which statistical skills should be and how to master meta-analysis review? Do we always need to ask the authors to access the raw original data from selected publications for a meta-analysis? Obviously, there are quite a few questions and sub-questions within it. Do you want to start answering them?
Yes. So I think that systematic review and meta-analysis now is a challenging study, because we are facing problems with that, as I just mentioned. I think that when you have the primary study and you cannot extract the data from the study, you have to contact the authors to get the raw data. This is very important. If you cannot obtain the raw data or the correct information, then you probably should not include this study in the systematic review and meta-analysis. I think I answered one of the questions, and I think that the Cochrane handbook, it's a very good start for those who want to introduce themselves in this world of systematic review and meta-analysis. For example, I have a personal experience. My wife conducted systematic review and meta-analysis in the Cochrane collaboration, and it took her 8 years to publish the systematic review meta-analysis. So they are very meticulous. They are very thorough review. So it's different from what we usually see now in this published systematic review meta-analysis in the journals.
Yeah, well said. Doing a very good systematic review and meta-analysis takes time and a lot of efforts going through the articles and trying to get the data as well. So currently there are quite a few courses, online courses, and if people have access to the university departments, then especially public health, and epidemiological centers, they do have people who will be able to assist it. So I think my advice would be to reach out to the nearest academic center, university, where you can access to some of the online courses and some lectures, which are already pre-recorded lectures and so on, which will help. Yeah. Now, can I ask the panelists now? Roque, you mentioned about number needed to treat and dropout. Do you want to voice it out, what you were thinking about?
Yeah, but there's a lot of parts of the good study, but I think that dropouts are something that sometimes we don't take into account. And that's quite important because the results can be different if you don't take this point in importantly. And the second thing is that the numbers to try to know exactly the effect. And that's the number needed to treat or the number needed to harm. That's probably interesting when you are introducing a new treatment, talking about drugs or instruments and so on. So that's is the best numbers. And another thing I wanted to say at the very beginning, you should talk with the statisticians. At the moment you are trying to get a trial in your harm or in your way to treat something especially, and the numbers should be important in the very beginning. So we need a statistician with us, and if not, at the end you cannot get the numbers he needs.
Good. Yeah. Thanks for those comments.
Purnima,
I was just about to ask you.
I'm challenging Fauze a little bit here with this question. I mean, 20 years ago, and I'm not going to pretend I actually read papers 20 years ago, but 20 years ago, there were nowhere near as many meta-analyses published, as you said in your second slide or something, right? And there are now. And I think part of this is reflecting that there is a demand for conglomeration of data, not just data from one center, but data that will give us a picture of a broader picture than you would get from one randomized controlled trial. But the reality is that we really can't afford to do 20 or 30 randomized controlled trials all over the world. And you would also ask the question, is there any point in spending money on another randomized controlled trial when someone else has apparently done a really good job, right? They've got the power, they've answered the question. Why would I now spend another $100,000 running my own randomized controlled trial here in Australia when the US has just done a great job on answering the same question? But then, you know, as an editor journal, you're looking at this saying, well, there's not enough randomized controlled trials to run a meta-analysis. So talk us through what we should be looking at when we're looking at randomized controlled trials, and whether, you know, is it good enough to have a smaller study that may not be fully powered? Is that still worth doing? I mean, can you talk us through some of those issues?
Thank you, Purnima. This was a really good question. So I think, yes, I think it's worthwhile to produce a small randomized control trial if the initial intention was to have the adequate sample size. I have experienced this situation myself. I tried to put together a study on hemospray for the treatment of patients with bleeding from cancer. And I calculated the sample size, but then I faced the pandemic, I faced the withdrawal of the hemospray from the market, and then I have to simply stop the study. So my intention was good, but finally I have to stop the paper. So I think it's worthwhile to conduct trials with good intention, with good sample size calculation. And if bad things happen in the way, you're gonna publish an underpowered trial, unfortunately. But if you have good quality randomized control trials, I fully agree that the way to go is to perform a systematic review and meta-analysis and not perform a fourth or fifth randomized control trials. I fully agree with you. I do not agree to do a bad quality randomized meta-analysis. I mean, to lump together bad quality studies and try to show that now you have good quality evidence, because this is basically what we are reading in the journals. Even in our journals, we are reading this repeatedly. And this is very common with papers that deal with technical aspects of endoscopy, with new techniques, with novel instruments. So I think that we are in the two extremes. You have good quality papers, the way to go, systematic review and meta-analysis. You have bad quality papers, please do randomized control trials, even if there is a risk that will be underpowered, even if there is a risk that you're going to spend money and do not reach what you meant to reach.
What about the question, as a follow-up question for you, what about a series of randomized controlled trials that were powered potentially to answer the primary question, but they may have been underpowered to answer the secondary question? Would you be supportive of a meta-analysis that would now look at maybe getting the secondary questions answered by doing a meta-analysis where these individual studies were performed properly, but not powered potentially to answer the primary, that secondary question?
Thank you for the question. And the answer is yes, definitely. This is one of the objectives of systematic review and meta-analysis. But it's important that the authors of the primary studies, they described that they would describe the secondary outcomes during the paper. So when they planned the study, the main outcome was mortality, but they described that the secondary outcomes would be frequency of adverse events, etc., etc. So if this is very well stated, then you probably can take these numbers, extract these numbers, pull together, and create a meta-analysis from this. The problem is when the authors, they do not intend, you do not have this data, and you contact them, they cannot say, oh, they just send some numbers that you feel that they are not correct numbers because they just wanted the paper to be included in your meta-analysis.
Good. Thanks, Fauze. My view is that sometimes you really cannot compare randomized controlled trials, because we have not uncommonly seen two randomized controlled trials coming up with two different answers. And if you go and look carefully into it, then you will realize that some of the methodology of the study and even the endpoints might not be the same. And even the inclusion criteria might not have been the same. So, so doing a randomized controlled trial in one particular aspect of it, for example, endoscopy and endoscopic intervention, the inclusion criteria may be a 2 centimeter polyp or 3 centimeter polyp. The other RCT might have done it with larger polyps. So the answer to it and the outcomes might be different, because one intervention might be good for a 1 centimeter polyp compared to a 3 centimeter polyp. So the whole thing might change. So that's where you need to critically look into although it is an RCT, looking at first glance, it might be a polypectomy. And then if you go a bit more deeper into it, then you'll realize that the inclusion criteria was slightly different. So that's something which I tend to look into when there are too many RCTs coming through, then see what exactly happened, why people are doing it. Yeah, that's a valid question about whether we should be repeating it. And also the patient population, because when you're doing a trial, obviously you are limited to the region where you are, whether you're in the UK or in India or in Australia, then your population might not be a generalizable population. And you might be in Brazil or South America, and even the acceptance of the treatment might not be the same. So that's quite a few things which can vary, repeating the trial in a different setting as well, I suppose.
I would like to include my question to this one about the consent to be part of a trial, and you should offer the proper treatment or the best treatment in that setting, that the patient should know exactly which is his options, and that's something that it does not occur.
Yes. I think you both tackled important points. Krish tackled the fundamental point, systematic review and meta-analysis. If the primary studies, you can lump the results together. You must respect some premises of inclusion criteria, etc. But this is, who decides this is the author of the meta-analysis. And this is very important, because when you read a systematic review meta-analysis, sometimes you do not notice this. You just take the abstract from the systematic review meta-analysis, and this is the best evidence, I'm happy with that. And unfortunately, the authors, they lump together studies that should never have lumped together. So this is key. And Roque tackled a very important point. Consenting is critical for clinical trials. And even when we are testing novel technologies in pilot trials, the patient should be consented, should be aware that this is a novel technology, and the risks and the advantage, the potential benefits for the patient. So definitely very important. Thank you, Roque.
We discussed a lot about these large meta-analyses and very powerful look, but they all come, even on your first or third or something slide there, from smaller and weaker studies. And the vast majority of the studies that we end up reviewing are probably more in that basket of, maybe not quite there. Do you have some idea of what characteristics of these sort of weaker studies, retrospective analyses and case series differentiate a good paper or a well-done study from one that you really don't think is going to add to the literature?
Once again, very good question. Thank you, Purnima. I would say that when I look at this case series, especially those one with novel technologies, I know that I'm gonna face a paper with huge selection bias. I know that when you first test a technology, you're gonna select the best cases for this technology. So I think it's valid to publish, but the authors at the description should be very transparent that they selected the good patients for this novel technology, that the study comes from a tertiary academic centers where there are a lot of experts in that procedure, and maybe this is a limitation for external validity, external validation of the study, and etc. So I think that these papers are useful to show the initial path, the way to go, and we should look at them this way. But what I see sometimes is that some authors are very excited about the technology, and they overinflate the results, they overinflate the conclusions. So I think that our task is, as editors, is exactly to tone down and to show, look, this is just 10 patients in a novel technology, very well selected patients. Maybe this will be not the case when we apply this in the regional hospitals, non-experts, and different levels of severity of the disease. I think, Purnima, it's in our hands to do this job.
Yes.
Yeah, well said. So I'm going to ask all three of you. We talked about the journal clubs and the juniors presenting in the journal clubs. So what advice would you give about choosing a paper? And as Purnima said, there are a lot of Me Too articles published in the journals. So how do you advise to pick a good article to analyze, which you can learn? And I start first with Fauze.
Okay, thank you. So I like to show both good quality and low quality randomized controlled trials for start, just to show, for example, in low quality randomized controlled trials when, for example, clear mistakes, randomization was not clearly described, there is clear bias in allocation, the sample size was not adequately calculated, the use of intermediate outcomes that are not clinically so meaningful as the main outcome, and so on, and show a good quality randomized control trial. So I do like this, and then I'm step down. I show lower quality studies in terms of study design, or otherwise we start with case series and then stepping up until we go to the randomized control trials and systematic review and meta-analysis.
Thanks for Purnima, do you want to comment on that? And how do you advise your juniors to choose a good example of a paper to discuss in your journal clubs?
It's interesting, actually. The way our journal clubs have worked has been a little bit different. And I wondered in the past whether we have taken as active a role in mentoring their choice of papers as we should, because it's a little bit of trial by fire. We usually start with something like an overall topic for the day, and 2 or 3 consultants and 2 or 3 juniors will all pick papers, okay, around 1 or 2 of these key topics that we think are important to help us answer a clinical question. And in theory, that should be how research is looked at. We have a question that we want to answer, and we want to see what the evidence is out there and what's the quality of the evidence to do what it is that we're doing. And then these researchers or these people have come forward with their papers, and then as a group we analyze it together. Whether or not that's the exact way of helping to teach people how to analyze papers, we can certainly find very quickly holes in the literature, and I think that's how we've been doing the teaching. And perhaps we've been relying that juniors, as they come through, have been given some kind of basis on how to read literature, which I'm not entirely sure that they do in our circumstance.
Yeah, that's interesting. Clearly, there is a different way of running a journal club. And it also depends on the key questions or what you want to achieve from a journal club. As you rightly said, you have a clinical question and you run a journal club, and you ask people to pick a few articles on that particular topic and then do it. Then it really gives a flavor of an intervention or a new drug or a new endoscopic procedure, whether it's worthwhile to do it or not in your setting and so on. But it may or may not give good experience or a feedback the trainee to push them up to read a paper. On the other hand, if it is a one-to-one, like someone, okay, fine, this week it is going to be consultant XY, and the trainee is going to be YZ, and you two guys decide what paper you want to present, and then the consultant goes through the broad aspects of how to read it, and then the trainee does it, comes and presents it, and then everyone analyzes. It might be a different way of doing the same thing, but maybe a more one-to-one. So that's a different ways of doing things.
Do you think the biggest weakness that we've found has been the lack of understanding of good statistics?
Absolutely, that's always been the case with clinicians, when we are quite busy and we lose our patience as well doing statistics, because numbers becomes a bit boring for some of us. We are more interested in the outcomes and what happens to the patient, more than looking into the 0.001 or 0.002 sort of a thing. So, but I personally believe that the statistics, biostatistics, is very, very important.
Absolutely.
And with my current role as director of research for Curtin Medical School, I've been insisting on putting it through the medical students coming through in the curriculum, where biostatistics is taught right at year 1, year 2 level, so that they have a better understanding of it when they come to the clinical area, so that they know why they do it. So I think a lot needs to happen at that stage. It's not something what you start doing it when you become a consultant or even a senior trainee. So that's something to look at. Thanks for your question. Let me ask Roque how they run it in the unit in Santiago.
Well, in my trainees, it's a key part of their training, and the journal clubs are trying to get interesting and something that has clinical impact is a challenge. So that's the way to teach them not only about critical studies and so on, but also with the clinical problem itself. And we have two ways to choose it. The trainees should choose one randomized controlled trial by their own. And I myself get another one, which is quite good or has some problems. I always think about the treatment of microbiota transplantation, and the fact that article especially had an interim analysis that changed the world at that time. And that's something that always beats me. And I talk about that article with the trainees, how change in the position article changed the life from then and on. And that's impressive, that result. And I don't know how they decided to make an interim analysis from the very beginning. And when you decide that your article is going to get an interim analysis, I don't know if Fauze could give me a sort of answer of that question.
I think that interim analysis should be planned beforehand. If interim analysis is not planned, I smell a rat. There is some problem with the paper. And if you plan interim analysis, definitely the level of certainty, the famous p-value, won't be 0.05. It will be much less than this in order to accept. So this is a very common mistake. You see the trials that are stopped before the accrual of the whole study population, and they perform interim analysis and employ the p below 0.05, which is not acceptable. So there are chapters on this. So how to perform interim analysis, how to correct statistically the p-value, and other ways to deal with that. So I think the most important for us as readers is to be sure that the interim analysis was planned beforehand. This is key to accept the quality of the interim analysis, and that statistically it was given a different treatment for the results. And I'd like also to add in a comment on non-inferiority trials. Non-inferiority trials, they usually demand a smaller sample size, which is good to conduct the trial. And then the authors, they do this common mistake. They find a difference, and then they transform it in a superiority trial. So I trying to show that the drug B is not inferior to A. And then all of a sudden, I noticed that B is a little better than A. And then I use the same sample size and show that B is better than A. So this is totally inadequate. This is another common mistake that we see. So this is very basic statistics, but we as readers, we should be aware of that. Otherwise, we're gonna buy this. We're gonna buy, in Brazil, we say cat for fish or fish for cat, something like this.
That's interesting comparison. Yeah, I agree. I think interim analysis are usually done when there are studies where one group of patients can be harmed if a drug is not given to them or an intervention is not done. Then it is good to do an interim analysis and maybe stop the trial as well if one group is getting more benefit and the other one is missing out on a life-saving treatment or so. So those are the areas where sometimes interim analysis are done to make sure that they don't harm the patients. And sometimes the ethics department also asks them to do an interim analysis when there are some endoscopic interventions which can be life-saving. Yes, Fauze.
I like to add that interim analysis should be audited externally. So it's not for the authors to decide on interim analysis. It's just some other investigators that are not involved in the study, directly in the study, but they're auditing. They should determine the interim analysis. There is this very interesting paper on the treatment of leukemia. And in the middle of the paper, the mortality was twice in one group compared to the others. And the authors want to stop because they thought that they were harming the patients, but the external audit decided to continue. And in the end, there was a balance and the mortality was very similar between the groups. So I think that the external audit is key for interim analysis. The investigators shouldn't be deciding on this.
Absolutely. That's the trial management group. Good. Okay, we are almost finished now. We just got 2 minutes. I'm going to ask all three of you, I'll say as well, in 30 seconds, tell me how you read a paper. I will start with Fauze. In 30 seconds, tell me how you, if I give you a paper, how will you read it? In 30 seconds.
Okay. Title and abstract, extract the research question. Is it meaningful? It makes sense. Then to go how the study population, source of bias, important source of bias, then results, magnitude, precision, and then conclusion, how it was presented, the conclusions, and then decide if I accept this or not from my patients.
Very good, spot on, you're on time. Purnima, get on now.
Again, okay, I do obviously title and abstract first, and then I go straight to the methods actually to see where they got the patients from, how many patients they had in their group, and whether or not their methodology would be able to answer the question that they wanted to answer in the first place. Then I go and see what the results are.
Good, okay, well done. Roque.
Well, I go first for the title and the importance in my real practice and in my trainees. And the authors is also something I take into account. And the abstract makes me clear what's happening with the article in deep. And then I go to the introduction, which is the state of the art for me. That's very good for my trainees. And then to the methodology, and exactly what Fauze has said perfectly. And the best part of the article is discussion for me, because it makes me sense of what's going on with the problem. That's it. And I ask all my trainees to get the consort here in his pocket all the time.
Good, thank you very much. So that's interesting. Almost we all do the same thing. So for me, as you all said, I quickly look at the title, abstract. That's the first part. Second part, a bit more detail if it interests me. And finally, third part, if I'm going to be really doing some presentation of the article, or I'm going to be reviewing that paper. I think we are just about at 8 o'clock. Sorry, my time, 1 hour. Thank you so much for participating, and we have all been on time. And I really appreciate everyone participating and all the attendees who are logged in. Thank you.
Thank you. Bye-bye.
Thank you. Thank you so much. Bye-bye. Thank you, you all.